Now I'm requesting Professor Imad Seiban when one stent is enough in bifurcation lesion. Dr. Imad Seiban is very much very much famous in our Bangladesh. You know, he contributes a lot to develop our interventional cardiology, and he several times visit Bangladesh to develop our interventional fellows and training program. So it's my honor and privilege to ask to give his talk when one stent is enough. Dr. Shivan, can you share your slide?
Yes, I shared. Do you see my slides?
Yeah, fine, fantastic.
Yeah. Okay. Thank you very much for the invitation. I am really happy to be here with you, to join you in this important meeting, and to share discussions and opinions. I think it is very important every time to learn something. My talk today is about left main, distal left main disease. I know that my friend David will not be happy to know that we can also make the bifurcation, distal bifurcation, very simply, sometime with single stent, and this will be contributing to have better outcome in our patient. So I will speak about, will focus on when one stent is enough. We know that these are various scenarios. I am sure that some of these patients should, the only option should be on surgery. But on the other hand, I think many of these scenarios can also be treated simply with angioplasty. Every time we are having some distal bifurcation disease, as every bifurcation, same question, one or two stents. And I think that the strategy in bifurcation lesion in general depends on side branch mainly. That means starting with clinical relevance, which is not the case of left main, because in left main, side branch is main vessel, is not side branch. The lesion severity, of course, is important, and the length of lesion on side branch is important. Disease extension, that means if side branch having more distally disease, distally to the proximal part, and the angle, of course, is very important. Calcification are very important as well. So the second question, do we have universally accepted criteria to select the right strategy? Well, we have some classification. We know that these are classification are coming also something or recent like this ABCD, but we still based on only distribution of plaque in order to have some idea about complexity of bifurcation. Then the Medina is the most used, and bifurcation like this is almost considered in all studies, I would say, it is a complex bifurcation because it is simply 1-1-1. And if we look on meta-analysis coming from these studies, we see that there is no difference. That means no difference using one stent as compared to stents. I will not show you that much data, but this is one of the recent meta-analysis, including different studies and different randomized studies, and no difference in total MACE. That means target lesion, revascularization, myocardial infarction, stent thrombosis are the same, are equally distributed between the two groups. But if we look on other scenarios and look particularly in side branch, we can see that we have the angle and calcification might be very important in selecting our strategy, as well as distribution, diffuse disease here in proximal part, tortuosity, and then expected dissection after pre-dilatation. Then all these elements are not present in any classification. So we do not have universally something that indicate to us which is the case to use one stent and which is the case to use two stents. If we look again, I think we have seen these scenarios many times, all defined by 1-1-1 Medina, but you all will agree with me that it's not the same strategy for all these anatomical scenarios. So what has happened more recently, that means after definition one study, we have some criteria now in order related to the not only to distribution of plaque, but also characteristics of plaques. That means how much is the severity, extension of disease, the angle, and so on, which permits us to define what is simple and what is complex. And this is coming from definition one study. I will not go in details or all these criteria, but to show you that what is defined simple bifurcation by definition, then single stenting is significantly superior to two stents technique. And this is the first time that on the first study showing that single stent is doing better than two stents, as well as in complex bifurcation. This is the first time showing that two stents are doing better than single stent in complex bifurcation. So what is necessary, what is essential is to define what is simple and what's complex. Then when simple bifurcation is present, simple stenting will be the default option. If we look now on some recent study like this EBC main 1 year result, you can see that the results are quite similar. That means no advantage of what single stent over two stents. But if we look on side vessel, that what was considered side branch, you can see now in both arms, the side branch lesion length was inferior to 10 millimeters. That means was short lesion in both groups. If we look on definition two study, which is dealing with the same, that means one provisional stenting versus two stents technique, but in complex, what is defined complex bifurcation, then you can see that lesion length on side branch is more than 10 millimeters in almost 95% of cases. And here is clearly shown in this kind of patient, then and the distribution of lesion on side branch, then two stents technique is better than single stent. And this is also coming from this huge meta-analysis showing that there is some difference between single technique used against provisional, and the only one is DK crush. But the most important thing that this difference is coming only for lesions that having length side branch on side branch having a length more than 10 millimeters. So I think the lesion length of side branch is very important issue and very important criteria to take in consideration. Again, other data coming, this is coming from Excel, showing that no difference in one stents as compared to two stents. But if we look also in more detail, when you have both ostium of both branches of bifurcation are involved, there is a trend to do better with two stents rather than one stent. And again, this is another study comparing one to single stenting to double stenting techniques in distal lift main, showing no difference. But again, if we look on length of lesion of side branch, what is considered side branch, still less than 10 millimeters. So I think one of the criteria to when one stent can be enough is length of lesion of side branch. When it is less than 10 millimeters, I think, yes, this is a good criteria to go for single stenting. Again, some other data coming from this study and showing the same. Again, no difference if you have lesion length on side branch less than 10 millimeters. But what is also important, I think what we have learned through the last years, that optimization of stenting can make the difference, and this is essential. And not only for complex stenting, but also in simple stenting, that means provisional, as well as in all other techniques to stent for double stenting. And of course, the operator experience in practicing and optimizing a single or double stenting technique is probably more relevant than the specific approach itself. But of course, we have to optimize, we have to be guided by something more detailed if as compared to angio, and this is the intravascular imaging, which might help us to plan our procedure. The functional evaluation can also give some contribution, intra-procedural guidance to do what is necessary for the patient and to optimize. This is what very important, to optimize the final result. And particularly important in left main is to size correctly the stent, and beside the distribution of plaque and the involvement of the side vessel in the bifurcation lesion. Also, sizing the stent is very important, because particularly important in left main is to the opposition of the stent in left main itself, and the opposition and the full expansion. And as we know, there's always a mismatch between left main and the two vessels of bifurcation. And another important thing is the stent characteristics. I think we should know about what we are using and how much we can expand the stent. And then coming to the procedure itself, I think we have we should go step by step in order to obtain the maximum of the maximal, let's say, result from any procedure we are doing. And same is applied also for provisional stenting, even if it could seem it's much more easier than a two-stent technique. Then I think pre-dilatation will go with step by step. This is the case for very short lesion on proximal distal left main involving LAD, and it is not enough to have only angio. I think you should check by IVUS in order to see exactly the distribution and whether if you can go with single stent or not in for this lesion. And after this, the first is wiring, imaging, pre-dilatation, and lesion preparation. Then after this, the second will be stenting main vessel with jail wire in the side vessel. Then the third step is to go for pot, adequately sized to left main, what you have measured already by IVUS. And after this, check your angio. If no compromise, and also intravascular imaging, if you don't have any compromise of side branch, your procedure can be considered finished. But if you have some like this, I mean, this is a full success in this case. But if you will have some compromised side branch, then the next step will be to cross to side branch, cross distally, and to go for kissing balloon inflation, and then repot in order to avoid leaving any deformation on the stent, as you can see in this case. Again, sometimes you also can spare stenting where is not necessary, and in this FFR can help much, as in this case after stenting, crossover stenting. You can see circumflex here have FFR 080 with some compromise on the osteomus of CER. Just with going with the small balloon 2.5, the side balloon at 8 atmosphere, after first inflation, we'll have this, and with FFR coming back to normal, and the patient should be left like this. And if you check with IVUS, you'll see everything in place. Also, the ostium circumflex is okay, and you can leave it like this without any unnecessary stenting. And we have enough data today to show that leaving after FFR evaluation, deferring what is not necessary is safe, and maybe it's much safer for the patient than stenting. Finally, about every one of us will or many times I was asked whether it is necessary to go for kissing balloon every time you are doing provisional stenting. I think this study, which is recently published in Circulation by our group, will show you that when you are dealing with single stenting, there is no difference between kissing balloon yes or kissing balloon no, as you can see in any of endpoints that mean death, myocardial infarction, target lesion, vessel revascularization, and even stent thrombosis, no difference. If you look on double stenting, then if you leave patient without kissing balloon, then you might have more target lesion revascularization, more target vessel revascularization, and this will also increase total MACE. So kissing balloon inflation should be mandatory only when you are doing two stents strategy. If you are doing single stent strategy, you don't have any compromise with side branch, consider your procedure finished even without kissing balloon inflation. We know that in provisional stenting today, we have some alternative, even if we do not have that much clinical support. But one is the side branch and pot, then pot, side branch and repot. All these are alternative to kissing balloon inflation, but still lacking in some clinical support. Then in some situation, you might go for stenting, because if you're still having a persistent significant compromised side branch, I think we should, in these cases, which are very few, to go for shift to two stents technique. But please remember that if you are shifting to two stents technique, then choose the right technique. That means in this, if after crossing, after overcrossing with in provisional stenting, the only alternative could be T-stenting or TAP or culotte technique, as you can see. But if we look on this meta-analysis, which comparing different approaches in bifurcation stenting, you see that TAP, which is most indicated for shifting from provisional to two stents, is associated with the worst result in terms of target lesion revascularization, in terms of target vessel revascularization, in terms of stent thrombosis, and in terms of death as well. And culotte also is not that much. I think the main thing is to avoid any protrusion or any overlapping of metals in this particular situation. And that means go for T-stenting if possible without overlapping or protruding in main vessel. And if we look on why you should do this, you see that that if you are shifting from provisional stenting to provisional two stents technique, then you will have more probability to have more MACE, increased MACE on long term. I think the ideal case where a single stenting can be enough is this one. That means when you have distal liftment without any involvement of side branch, side vessel, and you can see also on IVUS after stenting, everything in place. And I think also if you look on stent, how we should stent in this situation, you see that the optimization should be give a good conformability of the stent to the bifurcation in distal left main. Like you can see by stent boost in this case. Again, this is another good example for single stenting, since it is limited only to distal lift main and single and only single vessel involvement. And again, check on your final result. You should have something like this: full expansion of the stent in lift main, and full expansion in where it's crossing over, but the conformability of the stent bifurcation is perfect, as you can see here. So I will finish with this flow chart given by Latorre Fernandez for distal lift main when you go for single stenting, and you should leave it as single stenting until you do not have a very compromised, I mean, a very threatening abrupt closure of the vessel. Then otherwise you can stop without leaving the side branch without treatment, as I have shown you before. That means guided by FFR. Then to conclude, or to summarize, I think generally in bifurcation, you should go for one option is keep it open when you have very small side branch, but it's not the case of distal lift main, because we are dealing with something that is not side branch but is main vessel. So if you have a distal lift main, you have severe lesion on side branch, lesion length less than 10 millimeters, the angle is in between 45 and less than 70, no severe calcification, no thrombus, single bifurcation, not multiple bifurcation, then this should be considered simple, and this should go for elective simple stenting. And I would say at least 70%, 75% of cases we are doing are included in this kind of lesion. Otherwise, all the other lesions to be considered complex bifurcation and electively to be treated by 2 stents. Thank you very much for your attention.
Thank you, Seiban, for your nice presentation. Actually, seeing is believing, and as well as we believe this philosophy, and as because Imad, Seiban, and Marlos Farang also visited Bangladesh, they see the Bangladesh. That's why they believe to contribute to development of international cardiology in Bangladesh. And also I believe something has to be believed without saying. So I believe this philosophy also similarly. David Taggart and Saul Yangshan will be here to without seeing Bangladesh. They also contribute to develop our international cardiology. Thank you very much. I want to take 1 or 2 questions from cardiac surgeons. Professor Farooq Ahmed, sir, are you in line, sir? Yes. Would you like to make any comment regarding considering distal left and bifurcation stenting technique, 1 stent or 2 stent, whatever you like? Any comment from surgical point of view?
From surgical point of view, I like to personally is welcome if it can be done properly without disturbing the circumflex and keeping the circumflex open. If it can be done, that's most welcome. Thing is that so long, to me, my philosophy is the surgery should be the last choice. Before, if anything is available before that, the chance should be taken there. And I'm very friendly with my cardiologist friends, and they know always I say, if you can do it, that's better. If you can't and nothing can be done, then only option surgery.
Actually, it's our privilege. You are cardiologist friendly, but we also believe we should be patients friendly. But I appreciate your effort. Second thing, I want to take one more single comment from Dr. Mahbub Rahman from Levitt Hospital Consultant. Are you in line?
Unmute, please. Unmute, please.
Yes, thank you very much, Dr. Professor Azam. Actually, I enjoyed the lectures very patiently, and I had experience to work with Dr. Imad Seiban in Levitt Cardiac Hospital before, and I learned a lot of things from him. particularly bifurcation techniques and practical things. I'm very delighted to see him again, and thank you very much for everybody.
Thank you, Mahbub Rahman.
you.
And now
Thank
I'm
you.
requesting our Secretary General, Professor Mir Jamaluddin sir, make any comment regarding this point of view.
Thank you, Professor Imad Seiban. I am also grateful to you. And one thing I remember you that you worked with us, or we worked with you in National Institute of Cardiovascular Diseases one day. And thank you once again for participating in this program. Then the scientific question is to you. For distal left main, we feel well to do the distal left main. But if we remain within syntax score 32, we want to do all the cases. We do not want to send the patient to the surgeon if up to the syntax 32. And if more than that, then we usually prefer it to send the surgeon. Will you comment on it?
Well, I think that I totally agree that today we know that many patients with diffuse disease are for surgeon. But in the same time, I think that we have learned how to do angioplasty. It is not merely for just to be happy about the result, but what is important for the patient is to limit what you are doing only for significant lesions, and to have that means to limit number of stents you are putting in the patient. So in this view, I think that even if a patient is still less than 32, I will not treat every lesion without knowing whether it is a significant lesion for the patient or not. So I will limit my treatment every time for culprit lesions, that means ischemic lesion, significant lesion. And in this, I think we can be helped enormously with FFR or IFR evaluation.
Thank you, Seiban.
Rajam, Dr. Rajam, can I
yeah.
ask one question to Imad?
Yeah, sure. Dr. Khan, Sadhuraman Khan, okay.
Yeah, Dr. Imad Seiban, just I'm just called like 10 years back, SB lesion length more than 5 millimeter, then it comes to more than 10 millimeter, and then it is more than 16 millimeter. So really, there's sometimes while doing the bifurcation two-stent strategy upfront, it becomes very much difficult whether we'll touch it or not. Why not the lesion severity of the side branch? Because that one is much more important, because even a 5 millimeter lesion, if the severity is more than 90%, we have to go for a upfront two-stent strategy. That should be, because otherwise we know that it will be compromised after main branch stenting. So it's better to go before upfront. So why that 5, 10, 16? Because that is creating a lot of just confusion sometimes, that I'm not going to touch that one.
Thank you, Professor Saidur Rahman, for your nice comment. But I like to add that we shall implant up to 60 millimeter, but we shall have to keep the space for surgeon, as because this stent may cause re-stenosis and further new block may or lesion may come in front of that 60 millimeter. So we shall have to keep the space for surgeon for the better management of our patients. Thank you.
No, I'm not asking that question. I'm questioning Dr. Imad, the different one.
Thank you, Dr. Khan. I think exciting events awaiting, because the Marlos Farang.
Can I make a quick comment, please?
Yes, sir. Yes, sir. I just come back to you.
Let me just
come back to you. Just wait, just 30 seconds.
Dr. Azam,
interesting events are waiting for next following two speakers. You know, the Marlos Farang will cover the bifurcation double stent strategy provisional, and Shaoliang Chen upfront two-stent strategy. I think after these two speakers, you can make a debate more interesting and more vibrant. Now, David, would you like to make any comment?
Thank you. So I'd first like to say, Imad, great to see you again, and a very nice talk.
Thank you. Same for me.
Thank you. But I have two reservations. The first is that most or a lot of the studies you showed us had 1 year outcomes. And if they don't have 5 year outcomes, they should be labeled with a health warning. This is an interim short-term analysis. The second thing that concerns me about what is happening in interventional cardiology is when we do a trial like Excel, in patients with low or intermediate severity disease that showed a very clearly survival benefit for patients undergoing CABG, even at 5 years, and remembering that many of these patients should have a life expectancy of 20 years. Yet when we have a trial with a very clear result, immediately it is ignored and we all turn away from it. So this is, I have no doubt whatsoever when you say technically you can do these things with 1 or 2 stents. I can leave my hospital at night and I can drive home using my feet to steer my car. I can do it, but it's not a good idea. So I'm still worried that when we have very strong evidence for things, we ignore it in terms of other studies with which are either very small or with very short-term follow-up.